human papillomavirus, HPV, and cervical cancer. Recent updates. HPV vaccination. Broadened vaccine recommendations. Extended age range. The HPV vaccine is now recommended for individuals up to age 45, broadening the previous upper limit of 26 years. This change aims to provide protection to a wider age group who may not have been vaccinated earlier in life. Vaccines available. The most commonly used vaccines include Gardasil 9, which protects against 9 HPV types, including those most commonly associated with cervical cancer, HPV 16 and 18, and genital warts, HPV 6 and 11. Impact on HPV prevalence. Reduction in HPV infections. Studies have shown a significant decrease in HPV infections in vaccinated populations. In countries with high vaccination coverage, the prevalence of vaccine-type HPV infections has dropped by over 80%. Herd immunity. High vaccination rates are also contributing to herd immunity, indirectly protecting those who are not vaccinated. Vaccination programs. School-based programs. Many countries have implemented school-based vaccination programs, achieving high coverage rates among adolescents. Catch-up campaigns, programs targeting older age groups, particularly those who missed routine vaccination, are helping to increase overall coverage. Screening methods. Primary HPV testing. HPV DNA testing. Primary HPV testing is becoming the standard over pap smears, cytology, due to its higher sensitivity. Women are typically screened starting at age 25 depending on the country's guidelines, and the interval between tests can be extended every 5 years when using HPV testing. Self-sampling. Emerging evidence supports the effectiveness of self-collected samples for HPV testing, potentially increasing screening uptake, especially in low-resource settings. County testing. HPV and cytology county testing. Some guidelines still recommend co-testing, HPV test plus pap smear, for certain age groups to maximize detection rates. Risk-based screening. Risk stratification. Advances in understanding the natural history of HPV infections and the development of cervical cancer are leading to risk-based screening strategies, which tailor the frequency and type of screening to an individual's risk factors. Treatment of precancerous lesions. Ablative and excisional treatments. Cryotherapy and loop electrosurgical excision procedure, LEEP. These are common methods for treating cervical intraepithelial neoplasia, CIN. Cryotherapy is effective for low-grade lesions, while LEEP is preferred for high-grade lesions. Cold knife conization. This surgical procedure is used for high-grade lesions, and when invasive cancer cannot be ruled out. Thermal ablation. New approaches. Thermal ablation, which uses a heated probe to destroy abnormal tissue, is gaining popularity due to its simplicity and effectiveness, particularly in low-resource settings. Pharmacological treatments. Topical agents. Research is ongoing into the use of topical treatments, such as imiquimod, for treating high-grade cervical lesions, offering a non-surgical option for patients. Conclusion. The fight against cervical cancer has seen significant advancements through improved HPV vaccination strategies, more effective and accessible screening methods, and evolving treatments for precancerous lesions. These combined efforts are driving down the incidence and mortality rates of cervical cancer worldwide. Ongoing research and public health initiatives continue to enhance these strategies, aiming for even greater reductions in the burden of this preventable disease. Thanks for watching this video.